So, as Mr. Farrington said, this presentation is how prostate cancer screening and early detection can save your life. And so we'll go over some of the basics about the prostate and prostate cancer, and then a little bit about data showing the importance of screening. I will not talk a lot about treatment, but if there are questions about that later on, we can get into that. These are my disclosures. So briefly, just to everybody can know, the prostate sits just below the bladder and the urine goes through the urethra, which is in the middle of the prostate. It also sits just in front of the rectum. So that's why when the doctor examines the prostate, they put a finger in the rectum to feel that. And the function, a lot of people don't necessarily know, it's really what's called a sex accessory organ. It produces a fluid that helps to break down semen so that or helps down to break the fluid so the semen can do its job in the female genital urinary tract. It does contain a portion of the urethra where the urine passes through. At puberty, until about your mid-20s, it's about 20 grams, which is the size of a walnut, but it can grow as we get older. So some men with or without prostate cancer may experience some changes in their urinary function due to the growth of the prostate. Some basics about prostate cancer: it is the most common solid organ cancer in men, number one, and is the second most common cause of cancer death in men. Currently, it is more prevalent and more aggressive in Black men. Black men in the US have the highest incidence in the world and over 2 times the death rate compared to white men. And much of this is due to Black men being less likely to receive screening or early detection and being less likely to receive treatment for prostate cancer. And when you're talking about screening for prostate cancer, the 2 ways that this is done is the PSA, or the prostate specific antigen, and this is a blood test, and the DRE, which is the digital rectal exam, which is self-explanatory. Just briefly, I'll go over the current screening guidelines. As of now, the American Urological Association recommends shared decision-making for men aged 55 to 69 with a normal life expectancy. And we define this as someone who has at least 10 years of life expectancy. They do recommend selected screening in men at a younger age, from 40 to 55, if they are at higher risk. And this includes men with a positive family history, such as a father, brothers, and in Black men. They do state that some men who are 70 and older and in excellent health may benefit from screening, but this needs to be a very selective population. The National Comprehensive Cancer Network also recommends shared decision-making. Their age range is a little more expansive, from 45 to 75. And they also state that frequency of testing can be lowered or lengthened in between times based on their baseline measurement. Again, they will give the option for select screening in very healthy men older than 75. But again, these men need to be in very good physical condition. Lastly, the United States Preventive Services Task Force has upgraded their screening recommendation from a D, which was not recommended, to a C. And this again emphasizes shared decision-making. So men aged 55 to 69 who are in reasonable health can discuss risks and benefits of screening if they wish to consider with their physician. Now, part of the reason for screening is that screening can allow for earlier stage of diagnosis. If you focus on the left hand of the screen, the majority of men are diagnosed with what's called localized disease, meaning that the cancer is only within the prostate. 13% of men, though, are diagnosed with disease that has spread to lymph nodes within the pelvis, and then 6% present with disease that has already metastasized or spread to other areas, such as the bone or other organs. Approximately 5% of men are unstaged at the time of diagnosis. This is important because if you focus on the right part of the screen, you can look at the 5-year relative survival based on the stage at diagnosis. As you can see, for localized and regional disease, these men should survive 5 years, up to 100%. However, you see a steep decline in survival down to 30% if there is distant disease. And the way to avoid being diagnosed at a late stage is through screening. As I stated before, the United States Preventive Services Task Force previously had a grade D recommendation, first in men over 75 and then in all men in 2011 and 2014. I'm not going to get too much detail on this graph, but on the left hand of the graph, you can see that the incidence of prostate cancer, depending on risk, was increasing over time. After 2011, you start to see a gradual decline. That top line shows a decline in the number of men who are diagnosed with low-risk disease. And this is a good thing because most men with low-risk disease do not require treatment, or if they do receive treatment, they can have excellent survival. And so a decrease in this number is good, and that is what would prevent over-treatment and over-diagnosis. Unfortunately, though, you can see in the next two lines, which are intermediate and high-risk disease, those are also decreasing over time. That means fewer high-grade cancers are being diagnosed at an earlier stage, and thus these men are more at risk for spread of disease. And as we saw in the previous slide, your chance of survival of 5 years starts to decline significantly if that cancer is allowed to spread. In this slide, this shows some of the results of biopsy outcomes since the change of the USPSTF. And again, you see an increase of 5.94 risk in cancer overall, an increase in Gleason 4+3, and an increase in high risk depending on which modality you use to determine high risk, D'Amico versus Capra. Now, this was early data, but it was determined to be a really problematic trend, and this is increasing even to this day. There have been some studies looking at PSA screening, and the most reliable one is the European randomized study for screening of prostate cancer, otherwise known as ERSPC. When the data was initially published at about 7 to 8 years, there was a difference in survival, but it was considered very narrow, and the risk of overdiagnosis and overtreatment was high. But in this more recent data shown here, the control group risk of death in the red line is now starting to separate from the group that received screening, now at 13 years. And the further along this goes, we start to see the impact of screening in a population of men. It's important to note that the ERSPC allow for screening every 2 to 3 years. So even without annual screening, these men are enjoying an improved survival. The other thing that has been noted is that with screening, and I'll show this last line here, the men who received screening were much less likely to present with metastatic disease or a PSA of 100. So if you look at the early group of men, and that's 0 to 3 years, the risk of metastatic disease or high PSA was 0.94, and 1 would be equal to an unscreened population. So really no difference. But if you go all the way to the last column, labeled 0 through 13, up to 13 years, that number is now 0.6. And what that means is there is a 40% reduction in the risk of presentation with metastatic disease or a PSA of over 100. And that is a significant reduction, even better than what is seen with mammography for breast cancer. And again, I'll refer back to the slide showing that your survival from localized disease to metastatic disease drops 70% at the 5-year mark. So this is a really critical piece of data. So if you review all of the screening patterns and what has happened since then, there has been some good. Number one, fewer low-grade cancers have been diagnosed. And so that prevents overdiagnosis of cancer that does not need to be treated, and prevents overtreatment of men who have low-grade disease. There's possibly decreased anxiety over fluctuations in PSA levels. Some men don't have a stable PSA either because of prostate growth or infection. And importantly, there's less exposure to diagnostic and treatment risks. There are risks that are associated with diagnosing cancer with a biopsy and then also treatment with surgery or radiation or some form. There is some bad, though, that has happened over the last several years. We're potentially missing treatable, intermediate, and high-risk disease, and I'll define this later. There's decreased opportunity for refinement of screening tools. And additionally, it misses the opportunity for active surveillance of men with low-risk disease. And then importantly, in the Black population, Black men, those who are uninsured, and those who have lower education will see even lower screening rates. And as we stated before, these men are a high-risk population at being diagnosed with more advanced disease. So just briefly, I've been asked frequently, what is a normal PSA? And to that, there's not really an answer. There's not a cutoff for PSA where there is no cancer. And you can certainly have cancer with a PSA that's very low. But what you have to do is take into account the age of a man, the size of the prostate, and prior PSA measurements to compare against. And importantly, the age that I mentioned first, a PSA of 6 in a man in his 80s is not nearly as concerning as a PSA of 6 in a man in his 50s. And so they're all factors that need to be taken into account when you're discussing screening with your physician. If the PSA is concerning, your doctor may recommend a prostate biopsy to be performed. So what do you do if the PSA is elevated? If it's minimally elevated, you can repeat it in 3 to 6 months just to confirm if it's truly rising or maybe it was a temporary rise due to infection or trauma. If there is evidence of infection from a urine culture, we do recommend giving antibiotics, and then you can repeat the PSA. Importantly, though, if there is no evidence of infection, antibiotics should not be reflexively given just because the PSA is elevated. And then if it is significantly elevated, consider imaging with an MRI and a prostate biopsy. This is how a biopsy is performed. There's an ultrasound that is used to visualize it, and we use a template to take biopsies of the prostate, which is then sent off to a pathologist to look at. And these are the patterns that they're looking. And usually you can't have just one pattern, but for the most part, there can be a mix of patterns. And so what the pathologist will do is take the 2 most common patterns and then add them together to give you your Gleason number. And so in this example, if it's mostly grade 3, which is low grade, and then a small portion is grade 4, which is a little bit higher, then you add that together and you would say the Gleason is Gleason 3 plus 4 equals 7. The vast majority of time, if you're going to get a Gleason number, it would range from 6 to 10. Very rarely do you see something less than 6 these days. I mentioned risk classification before, and just briefly, we'll look at how you define low, intermediate, and high risk. Low risk men have a PSA of less than 10, and the Gleason number is 6, and they have to have either a normal exam or they can have a small nodule of the prostate. You have to have all of these criteria to meet low risk. And as I mentioned before, a lot of these men do not require treatment. They can undergo active surveillance. Intermediate risk can be any of the following: a PSA of 10 to 20, a Gleason sum of 7, or a large nodule or a disease that's felt on both sides of the prostate. And then to meet higher risk classification, the PSA has to be over 20, or the Gleason number from 8 to 10, or a large nodule that can be felt outside the border of the prostate, or evidence of extraprostatic disease. So just to summarize, prostate cancer screening should be done in a shared decision-making model with the man and his physician, and screening should be performed using the digital rectal exam and the PSA blood test. Data has shown that changing in PSA screening patterns may affect survival. And importantly, screening trials in Europe have shown that screening can reduce the risk of death and the risk of metastatic disease over time. Prostate cancer, when diagnosed at an early stage, may not even require treatment or certainly can be watched with an active surveillance protocol. Otherwise, early stage prostate cancer has an excellent survival in men. Thank you for your attention, and we'll take questions at the end of the presentation.